Hello, good evening, everyone. Welcome to the FC5 basic module. My name is Dr. Saidulu. I'm a pharmacist in Hinduja Hospital. Uh, today, today's topic is qualitative research to understand the antimicrobial stewardship and prescribing behaviors by my friend and colleague, Dr. Rinda Nupatti. She is a clinical pharmacist by background and recently completed PhD from Amrita University, India. And she is the one of the only PharmD candidate finished her PhD, especially in this domain area. And she has been working very closely with the AMSP program at Amrita Hospital, Kerala since 2016, and also working on different research projects in collaboration with the universities in India as well as UK and South Africa. And Dr. Vinda has been selected as emerging leader in the international infectious diseases by the International Society for Infectious Diseases. And in fact, she's invited as a speaker for this in next IACD conference. I'm congratulating on myself on the behalf of FCPI. And she's also invited to speaker for national and international scientific events, including IDWeek 2021 and SITCON 23. And she has several publications on her credit. Welcome to Runda, and stage is yours.
Thank you so much, Saidulu. I'll just quickly share my screen. Right. So can you see my screen?
Yeah.
Great. So good evening, everyone. Thank you so much for joining today's session. So I'm here to actually discuss a very passionate topic for me, that is how you can use qualitative research to understand antimicrobial prescribing behaviors better. So before we proceed with the presentation, I would like to state that I have no disclosures to declare. So over the course of next, say 45 minutes, we will be discussing different aspects of qualitative research, how it is different from quantitative research, what are the various methods of doing qualitative research, how to analyze the data generated from this research methodology, and how one can apply qualitative research methods to understand antimicrobial prescribing behaviors. Right. So I'm sure many of you are attending or have attended clinical ward rounds as a part of your posting and later on as part of your work. So just imagine this to be a patient bedside and you are attending a ward round. So imagine that this is the patient in the center and it's a multidisciplinary ward round where there are different healthcare professionals who are actually standing around the patient. Say there is a senior resident at the patient, at the foot of the patient bed, who's actually narrating the patient case, giving all the updates. So while you as a pharmacist is standing in this multidisciplinary team, you might hear that, the patient has been started on an antibiotic. So you would go back and look for which antibiotic it is, what is the dose, is the dose correct, is the frequency correct, is it prescribed for the right duration? But have you actually wondered who actually came to that decision of prescribing that antibiotic, or why that particular antibiotic was started for this patient? So basically, qualitative research enables you to understand why do people behave the way they do. So to break it down, it actually helps you to understand the how and why of decision making. So we will, in the next few slides, we will be discussing more about this, and you will get a better idea about how you can use qualitative research methodology and how you can present the findings from these studies. So by definition, it's a research methodology that is multi-method in focus, involving an interpretive, naturalistic approach to its subject matter. It might sound a bit complicated, but I'll just try and break it down for you. So it basically means that qualitative research has different methods, and it's usually we use multiple methods when we are doing a qualitative research study. And it basically uses a naturalistic approach to its subject matter. It tries to understand the subjects in a more holistic manner, in a more wholesome manner. It tries to gather an in-depth understanding of human behavior and the reasons that govern such behavior. That is what I told previously. It basically helps you to understand why do people behave the way they do. So to just help you understand how qualitative and quantitative studies are different, so many of you would be familiar with quantitative research methods like your cohort study, your case control studies, randomized control trials. So at least you would have learned about it as a part of your PharmD curriculum. But unfortunately, qualitative research is something that's not taught in our curriculum, but it is a very important research methodology that actually gives you a lot of in-depth data. So for those who have done quantitative study, you would know that the data that you generate as part of quantitative studies is numerical. It's all numbers, it's quantities. But in contrast, when you do a qualitative study, its data is all textual, it's all descriptive, it's all in words, it's all text basically. Another difference is that in quantitative studies, it basically describes the characteristics of a population. So say in your patient population, X percentage was males, Y percentage was females, so and so percentage was in this age bracket. The comorbidities, if you see X percentage had diabetes, Y percentage had hypertension. So it basically gives you the general characteristics of your study population. But in contrast, in qualitative studies, it describes the individual experiences, group norms. And in quantitative, you know that before you start a quantitative study, you will take the help of a statistician and calculate a sample size. And you basically collect data until you reach that sample size. But in qualitative studies, there is no predetermined sample size that's calculated. We continue collecting data until you reach a thematic saturation. So thematic saturation is basically when adding new data is not going to add any more insights into the study. So that is when you actually put a stop to your data collection. Now let's look at some of the main strengths of qualitative studies. So the first is it's an in-depth data collection. So when you say it's an in-depth data collection, it will enable you to gather a lot of information, a lot of behaviors in your study population, and helps you find a lot of things which you may not be able to find by just doing a quantitative study. Another thing, as I mentioned, it is descriptive. So that again shows you how rich data you get from doing a qualitative study. And as I mentioned, it's a multi-method approach. So you use different methods of data collection, like you have your observations, interviews, focus group discussions. So don't worry about these methods. We will discuss about this in the coming slides. Now, like any other research methodology, qualitative studies also has its limitations. So in the previous slide, I told you that it's an in-depth data collection. So when you say it's an in-depth data collection, it automatically is going to mean that it is going to be time-consuming and labor-intensive. So when you do a qualitative study, you do hours and hours of observation, you do multiple interviews of healthcare professionals, multiple focus group discussion. So it is a very elaborate process, but the amount of data that you get is equally rewarding. So which is why people do qualitative research. Another main limitation of qualitative study is something known as Hawthorne effect. So it is basically a phenomenon wherein the study participants actually alter their behavior because of their awareness of being observed. So I'll explain it to you. So say you are doing an infection control study and you go to a ward to audit hand hygiene practices. So the consultants in a department is aware that you are there to audit their hand hygiene practices. So the minute they see you, they will naturally make an effort to do a lot of hand hygiene, to do all the necessary steps of hand hygiene, follow the 5 moments of hand hygiene, be very vigilant. So they become very conscious that you are there and they try to alter their behavior. So the observations that you get then is not actually not the actual behavior. It's giving you a more like a made up image. So that is what is called Hawthorne effect. So the data that you collect then is not giving you the actual behavior. So how do you overcome this Hawthorne effect? So basically what you do is you just continue going with them for observations. So you're not going just for 1 or 2 observations when you're doing qualitative research. It's just multiple episodes of observations that you do. So when you just prolong with your data collection, when you just go on following these teams, they reach a point when, they stop pretending. So they stop, giving you, they stop taking an effort to give you the right image, and they actually start showing you their actual practices. So then you understand, okay, this is how they are actually behaving. What you saw initially was actually not the exact or not the actual behavior in the department. So that's how you overcome Hawthorne effect. Another bias is researcher bias. So this is one main criticism also against qualitative studies. So how do one try to overcome researcher bias? It's by including multiple researchers to collect the data, and also including multiple data collection methods. So I'll just give you an example from the research study that we did here. So when we did a qualitative study in our hospital, like when I joined that study, I was already a practicing clinical pharmacist in the hospital. So I was familiar to the hospital environment, and I was familiar to the wards where we were doing our observations. So a lot of the practices that I saw there, I just overlooked them, thinking that, okay, this is the normal practice. There's nothing to be questioned there. And I never made a note of it. But I had a colleague who was an anthropologist by background, and she was completely new to the hospital environment. And for her, all these observations were new. So she started making a note of everything that she observed. And she did make a note of things that I actually missed. So what I observed and what she observed put together, that gave a complete picture. So, which is why including multiple researchers actually helps you to overcome this kind of researcher bias. So initially, I told you that there is no actual sample size calculation when you do a qualitative study. So what you do is you undertake non-probability sampling, like techniques called, purposive sampling or snowball sampling. Those are some methods that we use to actually select our study participants. So purposive sampling is basically when, for example, you create a criteria for your study participants, and you purposely select participants who meet the criteria. So it could be from your network, it could be from your contacts. So you purposely select those people whom you think can give you the maximum amount of data. Snowball sampling is different. Snowball sampling is when, say, you interview a participant, say you call the participant A. So you interview participant A, and once you're done with the interview, you ask that participant to also give contacts from their network who will be useful for the study. So from one participant, you're getting connected to another participant, from that to another participant. So it's like a snowball effect. So that is snowball sampling. So these are some of the techniques that we use in qualitative research to select our participants. And data is collected until thematic saturation. So I already explained to you what is that. Okay, so now let's talk about the qualitative research methods. So there are different methods, observations, interviews, focus group discussion, ethnography. But these are some of the key methods that's used in qualitative research. So we'll discuss about these in detail. So the first is observations. So observations is basically when you as a researcher follows your participants and you just observe their practices. So for example, you are looking at antimicrobial prescribing behaviors in a medical team, say in the general medicine department of your hospital. So you follow them during their ward rounds, during their outpatient clinic, during their departmental meetings, and you just observe the practices there. So observations are basically used to obtain detailed and accurate information about the setting, individual, community, or population under study. So it basically gives you a lot of data about what is happening in the department, what the environment is like, who are the major team players in the department, who are the decision makers. So it gives you a lot of data when you're actually doing these many, many hours of observation. So these observations can be of two types. You can have participant observation and you can have non-participant observation. So participant observation is basically when you as a researcher also gets involved in some of the activities of the subjects or the study participants. So for example, you are observing this general medicine team and you just get involved in their activities. Say, for example, you help them get the patient file, or you just draw the curtains around the patient bed during the ward rounds. You just get them their hand gel. So things like that, basic activities, but you're getting involved in their activities. Non-participant observation is when you as a researcher don't get involved in any of these activities, but just stay back and observe the subjects. So those are two different types of observation. So you choose your type of observation based on what is it that you want to achieve and your research question. So coming to the advantages and disadvantages, for observations. Advantages is that, like I mentioned, it helps you to understand the natural behavior of the study participants in their own environment. And observations are your interpretation of what you see. So it is the researcher's interpretation of what they are observing. And disadvantages, Hawthorne effect, which I explained to you in one of the previous slides. Okay, the next one is interviews. So observation was when you as a researcher was actually observing the participants in their environment, seeing what are the practices that they're doing. And interview is when you actually sit down with the participant and you try to get their perspective. So observation is your interpretation. Interviews are getting the participant's perspective. So it is like a one-on-one discussion designed to provide a detailed picture of participants' view of the area of interest. So you have observed something and now you're trying to get a complete picture by also understanding why the participant actually did that. So you ask questions during the interviews to basically also fill the gap in what you observed. So these interviews are usually scheduled based on the participants' availability at a date, place, and time that's convenient for the participants. And we usually record these interviews, but we make sure that none of the participant identifiable information is captured. So for example, in our interview transcripts, we will not have any name of the participant or anything that actually connects you to the participant. So even when you are using the data from the interviews in your publications, you don't say that, Dr. Raj from X hospital said this. You will just say that a consultant from a hospital in India said this. So it could be any consultant. So you're not giving any identifiable data of the participant, and that is made sure. And you first take the consent of the participant and then you go for the interview. So even when you're doing observations, you have to make sure that the ones who are being observed are aware why you are there. So you take a consent from them before you are doing the observation. So taking consent when doing qualitative research is very, very, very important. So please do not skip that step when you are doing this research method. So again, interviews can be different types. One is structured, the other is semi-structured, and the third is unstructured. So structured is when you have an interview guide, you have a set of questions, and you go in for the interview and just ask only those questions. Semi-structured is when you have an interview guide, but you are free to move around. So interview guide in semi-structured interviews is basically just giving you a guidance on what needs to be asked. But if you want to ask anything outside that interview guide, you are free to do that. So for example, when you're doing the interview, the participant might give you some information and you want to explore more on that. So you can start asking more questions which are not actually there in your interview guide. And unstructured is when you don't have an interview guide, you don't have a set of questions that you actually need to ask, but you go in for the interview and do it like more like a discussion sort of. So advantage of this is, like I mentioned, it helps in understanding the respondent's point of view, the participant's point of view. Disadvantages, it can be time consuming. So say one interview takes about 40 minutes to 1 hour. So if you are going to take interviews of healthcare professionals, patients, and everyone in the team, say you're taking about 40 interviews, 1 hour, 1 hour per interview, that takes you about 40 hours of data collection. So you can see how much time it will take for doing these kind of interviews. The next method is focus group discussion. So focus group discussion is a bit similar to interviews, but interview is like a one-on-one conversation. Focus group discussion is where you have multiple participants coming together. So you say, for example, you're doing the study in general medicine. You call all the consultants in that department and you do a focus group discussion. So you ask the question to all of them together. So it elicits responses and generate discussion among the participants based on a broad question. So the advantage here is that it, especially when you have a limited time for data collection, this focus group discussion helps you to gather maximum data in minimum time. So that's a major advantage. And disadvantage is that, like many of you would know, not everyone is comfortable to speak in a group. So when it's like a one-on-one conversation, some participants tend to speak more and give you more data. But when it's like a focus group discussion, they might just suppress their opinions and they may not be able to share it in front of the others. So that's a disadvantage of this method. The next is documentary analysis, where you review documents like public records, medical records, policies, guidelines. So those documents are reviewed. It is non-obtrusive in nature, which means that you don't actually need to interact with anyone or get or hinder any of the activities of the participants to collect the data. But disadvantage is that there might be lack of accuracy and consistency in documentation, which will impact your data collection. And documentary analysis is not used as like a standalone method for qualitative research. It is basically used as an add-on. So if you're doing observations and interviews, you can also add documentary analysis to it to give you a more wholesome picture of the practices in the department. The next method is case study. So you might be familiar with case studies that are quantitative in nature. So qualitative case studies are also quite similar, where you do like an up-close, in-depth, detailed examination of a subject. And when you do a case study, the case can be an individual, can be like an individual patient. It can be an organization. It can be an event or action at a specific point and space, specific time and place. So this case can be anything. So it could be doing like an in-depth study of one organization and their practices. That could be a case study. It could be just following a patient throughout their patient pathway and understanding everything. So the definition of case can vary when you're doing a case study. And you will use different methods of data collection when you're using a case study. So a few slides later, I'll talk about a case study that we did here as part of our qualitative research. And you will see that we used observations, interviews, and documentary analysis to do the case study. So advantage is that it supports arguments and statements put forward. Disadvantage is that it cannot be generalized for entire population. The similar disadvantage you have when you're doing case study, quantitative case studies. So it is a standalone thing. It may not be generalizable to a wider population. So again, case studies are usually done as an add-on method in addition to other qualitative study methods. The next one is ethnography, which is again a very important method. So in this figure, you can see ethno means people, graphy means writing. So ethnography is basically a very in-depth kind of data collection where the researcher basically immerses themselves as a subject in the participant population for extended periods of time. So it helps you to gather in-depth data collection and gives you like a wholesome picture of the practices in the department. And again, it's time consuming and labor intensive. So these are some of the major methods of qualitative data collection. Now we have to talk about something very important, that is data triangulation. So I mentioned when we talked about challenges or limitations of qualitative study, I mentioned about researcher bias, and to overcome that, we use different methods, different investigators. So that is a process called as data triangulation. So in data triangulation, we use various sources of data, various methods of data collection, various investigators collecting the data, and using multiple theories or hypotheses to do the data collection. So data that is generated from all these different sources gives you a complete picture, and you're basically triangulating the data from all these sources. So this practice actually helps you to enhance the credibility of your research study. Okay, now you have done your data collection. You have collected this enormous amount of data. So I told you already that the data that you collect as part of qualitative study is all textual in nature. It's all descriptive. It's all words. So when you go for observation rounds, you actually make notes of whatever you're observing. Interviews, you get interview transcripts, and that's again just paragraphs and paragraphs of words. So now how do you analyze the data? So when it's a quantitative study, you know that, you have, so you go in with a case report form or a data collection form, you collect the data that's required, you put it onto an Excel file, and then you put it onto softwares like SPSS, do all the analysis, and that will give you the data. I mean, that will give you the result, and that's how it is done in quantitative. But in qualitative, it's quite different. So you have this large amount of data. What you do is you sit down and read through all this data. So you sit and read through all your observation notes, you read through your transcripts, and then you start creating categories. So you once you read few transcripts or few documents, you will start getting an understanding about the behaviors, and you'll be able to start categorizing the data under different headings. So previously, it was all done manually. Now you have some computer softwares like NVivo and Atlas, which will help you to do this. But again, it's not like an automated process. These softwares help you to categorize the data, but again, there is a bit of manual work involved there. Once you categorize the data, from that, you will generate themes, and with that, you will present the findings. So this is basically how you sit down and do the analysis part of qualitative studies. Right. So now I have given you quite a broad overview of how qualitative research is done, how you analyze the data, how it's different from quantitative. Now let's look at some of the examples of published literature on how qualitative research was actually applied to understand antibiotic prescribing behavior. So this was a study, this was one of the first qualitative studies that I came across. This was done by my mentor, Dr. Smita Charani, and her team in London, where they looked at the various determinants of antimicrobial prescribing within hospitals. So this study found that antimicrobial prescribing is actually performed in an environment where the behavior of the clinical leaders or the seniors actually influence the decision making. So many a times there is something known as decision-making autonomy, where the senior members, they rely more on their experience and their knowledge rather than following the guidelines. And their decisions actually influence the decisions of the junior members also. So basically, the junior members of the team is actually only following the practices set in place by the senior members of the team. And then the study also found that there is a practice of non-interference. So consultants do not basically interfere with the prescriptions of another consultant in their department. So these kind of cultural rules shows the presence of something known as prescribing etiquette, which actually determine the antimicrobial prescribing in hospitals. So now, if you look at things like, decision-making autonomy and culture of hierarchy, you can't get these data from a quantitative research. But you would have observed during your clinical posting itself that these kind of nuanced things are actually playing a role in the decision making in the department. So let's look at another example. So in the previous one, you saw that there are certain nuanced determinants of antimicrobial prescribing. But is that same in all departments and in all hospitals? So in this study, the authors have tried to look at the difference in decision-making between medical and surgical departments. So they have done close to 400 hours of observation, multiple interviews of staff members, and documentary analysis. So this one figure here will give you an idea about what I was telling you, that it's the data collection is time consuming, it is labor intensive. So just imagine doing 400 close to 300 to 400 hours of observation. So it's basically following the participants during their ward rounds, during their departmental meetings, outpatient clinic, then doing in-depth interviews of staff members, documentary analysis of meeting notes, handover sheets, all these things. So this gives you an idea about how the data is actually collected when doing a qualitative research. So these are some of the key differences that the authors found between these two departments. So some of these include in the medical department, it was more collectivist approach, which means that they were more open to getting inputs from the different healthcare professionals who are involved in the team. And in surgical, it was more individualistic in nature. So it was basically one surgeon taking the decision, and it was that kind of an approach that they followed. Medical teams, they were less pressurized on wards. Surgical teams, as you know, their time is basically stretched between outpatient clinic, operation theater, wards, various places in the hospital. So they have very limited time that they spend on wards. So it was more pressurized for them. Medical teams, they preferred more face-to-face meetings, but surgical teams, they preferred more mobile phones for communication. Medical team, they try to rationalize their decision. They try to align their decisions with the policies, and they were welcoming inputs from other healthcare professionals. But surgical teams, they relied basically on infection markers to guide their decisions. Challenges also differed in these departments. In medical, it was basically the transition of patient between different departments, while in surgical, it was the fear of negative outcomes or fear of blame. So this study gives you an idea about how the approaches and how the behavior is different in different departments. So it is very important that, especially when you're doing antimicrobial stewardship interventions, we need to understand the behavior of the recipient department. Only then you can actually tailor or customize your intervention, which will help you to improve the uptake of your interventions. So for example, you are going to a surgical team and you're giving a recommendation to change a prescription, antibiotic prescription. And you go on to telling them, if you do it like this, it might lead to antibiotic resistance, that, this, they may not be interested in that. But select those matrices that actually matter to them, like surgical site infections, mortality rate, hospital readmission rates. So these are things that they are more concerned with. So tailor your recommendation in such a manner that it is more appealing, or more it catches the attention of the recipient more. So that will help you to improve your the recommendation acceptance also. So this is another study which was, again, that used qualitative interviews to understand antibiotic stewardship in a tertiary hospital in India. And the authors in the study, they did interviews and focus group discussion of physicians, clinical pharmacists, and microbiologists in the hospital. And they found different facilitators and barriers to the stewardship program in the hospital. So some of the facilitators included availability of microbiology services, high level of understanding of stewardship among the staff, easily accessible antibiogram and guidelines for empiric prescribing. On the other hand, barriers included physician resistance to changing their prescription, especially in case of antibiotic de-escalation, limited availability of clinical pharmacists, inadequate physical visibility of AMS activities. So this study basically tried to understand why, there are, what are some of the facilitators and barriers to stewardship in that hospital. So having an understanding about these is very important whenever you're developing interventions. So only once you address these barriers can you actually improve the compliance to stewardship recommendations. So you might be doing stewardship for quite a long period of time, and you see that there is no much changes in antibiotic prescribing behavior in your hospital. It is very important that you go back and analyze what are some of the barriers to to make that change happen. So it could be because the physicians are resistant to change their prescribing habits because they are fearing of negative outcomes for the patient, or it could be some patient factors like, patient may not be able to afford certain antibiotics, because of which the physicians are forced to continue certain medicines. So there are a lot of factors which play a role there. So it is important you have to do like an in-depth analysis on why the stewardship is not giving you the necessary results in the hospital, if that is a situation you're experiencing. Right. So with that, I would like to now discuss about a qualitative research that we did in our hospital. So this was basically a multi-centric, multi-method study. So it was not just qualitative research. Qualitative research was a major part of the study. It was basically looking at what are the key drivers of antimicrobial resistance and infection control across the surgical pathway in different countries. So given here are the different universities that collaborated on this work. And this study was funded by Economic and Social Research Council in the UK. So this study, as I mentioned, it included various methods, both quantitative and qualitative. I was predominantly involved in the qualitative part, wherein we did ethnographic research. So this study was basically done at Amrita Hospital in India and University of Cape Town in South Africa. Across these two study sites, we conducted hours and hours of observation throughout the patient pathway. So we did observations during the ward rounds, outpatient clinic, operation theater, departmental meetings. We conducted, so in India, we conducted 50 interviews of healthcare professionals and patients. We did 4 in-depth case studies and documentary analysis. So in addition to the ethnographic data collection, we also did in-depth case studies. So these case studies were actually conducted on patients who had post-operative complications, just to give us a contextual anchor to basically understand the findings from our ethnographic study. So in this particular figure, you can see how complex this patient pathway was. You can see there were too many healthcare professionals who were involved in the patient care. There were multiple episodes of infection in the patient, multiple antibiotics was prescribed. So basically, it gives you an idea about the complexity of infection management and antibiotic use in the surgical pathway, and the fact that it is infection and antibiotic use is not just an issue in the surgery period, but also even post-operative period as well. And the study also helped us to understand certain patient level factors, such as, economic background of the patient and how much, especially because in a country like India, majority of the patients pay healthcare expenses out of their own pocket. So patients might be having severe infections. They might need to be given a high-end antibiotic, which are quite costly, but patient may not be able to afford that antibiotic, which is why the physicians or the surgeons are forced to give an inferior antibiotic. So that again complicates the surgical pathway. So there are a lot of factors that is involved in this decision-making process. And these case studies actually helped us to understand that better. Then we also went in and looked at who are actually the decision makers when it comes to infection management and antibiotic use. So the triangle figure here represents who are the primary decision makers, who have the primary roles in decision making. And the circle here represents who are those who have a secondary role to play, or who are the secondary decision makers. So from this figure, you can understand that there are a lot of people who are involved in the decision-making around infection management and antibiotic use for surgical patients. You have the surgical team, intensive care team, antimicrobial stewardship team. So many people are involved in this patient care. But actually, the bulk of the decision-making was done by the surgical team and the intensive care unit team. We found that clinical pharmacists are present in the surgical team, but they are not very much actively involved in the decision-making part. When it came to nurses, again, they were not involved in the decision-making. Their responsibility was limited to administration of antibiotics. So it is important that we understand who are the decision makers, who are the primary decision makers, who are the secondary decision makers in a department. Because many a times what happens is that when you're doing antimicrobial stewardship, you tend to target the junior members of the team more. But essentially, these junior members would only be following the orders or instructions that are put forth by the senior members of the team. So they are just following the orders. They are not actually the decision makers in the team. So you need to understand who it is that you have to target to make the changes possible. Another important finding from our study was the role that patients and bystanders play in infection-related decision making. So we all know that in Indian healthcare setting, bystanders play a huge role, and they are required to be with the patient throughout the patient stay. We found that many of these patients are not actually aware that they are on antibiotics. Some of them, they were aware that antibiotics were given, but they were not aware of what the infection was actually being treated. And we found that the patients and bystanders prefer to stay in hospital. Many of them, they prefer to stay in hospital rather than being discharged, because they felt that when they are in hospital, they get more attention, more care from the healthcare providers, which they may not get once they are home. Another important finding was that the consultants informed us that many patients and bystanders actually associate clinical improvement with antibiotic use. So when antibiotics are not prescribed, these patients and bystanders actually demand for antibiotics. And in a healthcare system like India, where majority of the patients can actually choose their healthcare provider, there is a tendency, at least among some patients, to actually switch their consultants or change their consultants if they feel that their demand for antibiotic is not met. So that kind of influence also the patient can actually make in this decision making process. We also found that patients rely a lot on the voice and the role of bystanders in decision making. This you might be familiar even in your clinical setting, where many patients are not even aware about the issues that they are having, or the condition for which they are being treated. Many of the conversations are mostly between the healthcare providers and the bystanders. So they have a huge role to play when it comes to this decision making, at times even more than the patient has. We also looked at the role that patients and bystanders play in infection prevention and control. So many of the hospitals actually demand that a bystander be present with the patient at least when the patient is in wards. So in our hospital, even the hospital policy mandates the presence of a bystander throughout the patient's stay when the patient is not in the ICU. In all the other locations, you actually require a bystander to be present with the patient. Yeah, but they are not actually given a lot of education and training on infection prevention and control. They are the ones who are actually taking care of the patient and doing all the wound care and everything when the patient gets discharged from hospital. But a very formal kind of an education is not provided on a consistent basis to them. And they also provide a lot of inputs into the clinical decision making, like I mentioned in the previous slide. And at times that input is more than what the patient is giving. But again, they are not receiving the standard of formal education and training to actually support their contributions or their existing roles. So this is the last, I think, no, second last study that we'll be discussing. So this is a very interesting methodology, qualitative methodology. It's called sociograms. It is basically a visual mapping tool. So this study was actually done by my colleagues in South Africa as part of this Aspire study. So this is how a sociogram looks. I know it looks very colorful and it looks very interesting. So it basically tries to capture what is actually happening at the patient bedside. So I'll try and decode this whole figure for you. So here you can see a rectangle, and inside that it is written patient. That's your patient bed. You can see different shapes surrounding the patient. So those are different healthcare providers We can see a key at the lower right corner that says, triangle represents consultants, circle represents registrars. So registrars are someone like, your residents or senior residents in your hospital. So these are the different professionals who are actually attending these ward rounds. Now you can see different colored arrows that's going back and forth from the patient. So these colored arrows demonstrate the different communication themes. So you can see at the upper right corner, there is a key for that. So the orange color is representing culture and sensitivity data. Antibiotics is represented by pink line. Purple color shows asking questions. So now you can see there is one resident who's standing, a registrar who's standing at the foot of the patient bed, and he is giving out, he or she is giving out a lot of information about the patient. So this information includes culture and sensitivity report, antibiotic use, other clinical information, infection markers. So there's a lot of information that is being given about the patient, and it's not basically directed to anyone. It's just being given to the whole team. Then you can see that there is a consultant who is there. I think I'll just try to the pointer. Oh, oops, I think it's not working. No problem. So there is a consultant here. This consultant is actually asking questions to the patient. So you can see there's a purple line that goes to the patient and the patient is answering. So you see a back arrow towards the consultant. So from this figure, you can see that there's a lot of conversation happening between the consultant and the patient and between the consultant and the registrar. But the ones who are standing at the periphery of the beds, like your interns, your nurses, your medical students, they are not actually involved in any of these conversations. They are just observing, or they're just taking a back seat when all these things are happening at the patient bedside. So these sociogram basically helps you to understand what is happening during a ward round. So you might have attended multidisciplinary ward rounds, and you see that there are a lot of people who are actually attending these ward rounds. But are they all actually required to be there? Maybe not. So from this sociogram itself, you can understand that the majority of decision making is done by the registrars and the consultants. So the others are not basically even participating in this discussion and in this decision making. So this is what sociogram helps you to understand. So it gives you the nuanced data on what is actually happening during ward rounds at the patient bedside. So now I would like to just give you an example of one more study. So this is basically from my PhD work, where I try to look at the role of pharmacist in different settings. So we all know that guidelines like IDSA guidelines, CDC guidelines, they all endorse the role that pharmacists play in antimicrobial stewardship programs. But like we know, the extent to which pharmacists participate in these programs differ in different countries. So you would have seen that there are a lot of publications on pharmacist roles from high-income countries like UK and US, but countries like India or other low-middle-income countries, the pharmacist roles in stewardship is still evolving. So basically, I did a qualitative study to understand in detail on why there is a variation in pharmacist role between different countries. So the first aspect that I looked at was education and training of pharmacists in who are actually participating in stewardship program. So like I said, I did the study in India, South Africa, and United Kingdom. So in India, the pharmacists who participate in stewardship are Doctor of Pharmacy graduates. In South Africa, they are Bachelor of Pharmacy graduates. And in the UK, they are Master of Pharmacy graduates with opportunities for additional postgraduate qualification like independent prescribing, PhD, infectious diseases training. So that is the basic educational qualification of the pharmacist. But irrespective of whatever the qualification was, the pharmacist informed that they did not receive sufficient training in antimicrobial stewardship as part of their pharmacy curriculum. So how they were trained in antimicrobial stewardship was basically through self-motivated learning and support of mentors who were either senior pharmacists or doctors in the antimicrobial stewardship team. Then I went on to look at how much of a role and what all the different responsibilities that pharmacists take up in different countries. So in the UK, what I found was that the scope of pharmacists' responsibilities have actually expanded over time. And currently, there are hospitals that have pharmacist-led stewardship models. Some of them have dedicated pharmacy teams, and some of them still have ward pharmacists who are involved in stewardship programs. In South Africa, as I mentioned, the pharmacists who participate in stewardship are basically Bachelor of Pharmacy graduates, and they do stewardship in addition to their pharmacy responsibilities. So in the public hospitals, pharmacists felt that their role was secondary when there's a presence of an ID physician. And in the private hospitals, it was mostly a pharmacist-driven stewardship model. But in all these cases, these pharmacists were basically doing stewardship out of their own passion in addition to their pharmacy responsibilities. In India, all the clinical pharmacists who participated in the study were basically dedicated for antimicrobial stewardship. Now, when you look at facilitators, like I mentioned, in the UK, the pharmacist role has evolved over the years. And it is at this current stage because of collaborative work, improving skill, and actually showing the value of pharmacists in stewardship programs. In South Africa and India, the major facilitator that the participants cited was the support of senior doctors and hospital leadership for pharmacist roles in the program. So basically, the participants informed that when the senior doctors in the team accept pharmacist recommendation, that acceptance basically trickle down to the junior members of the team, and the whole department is more open towards pharmacist inputs. Coming to the challenges, even though I mentioned that, in the UK, pharmacist roles has evolved over the years, and it's at a more advanced stage compared to other countries, they still have certain challenges. For example, resistance from few departments like the surgical departments. Time is a challenge for at least few of the pharmacists, especially those who have additional ward responsibilities. In South Africa, lack of training was a major challenge that the participants cited. Time was a challenge, especially because these pharmacists were doing stewardship in addition to their pharmacy responsibilities. And there was also a shortage of personnel. In India, again, lack of training was a major challenge. Pharmacists still face resistance from clinicians to accept their recommendations or interventions. Human resource is a big challenge. And participants also felt that they were not sufficiently paid on par with their responsibilities in stewardship program. So this study basically gave me an idea of what are some of the factors that's actually contributing to pharmacists' roles in a program, and give me an understanding about why it is differing between different income settings. So UK is a high income country, South Africa is an upper middle income country, and India is a lower middle income country. So even when guidelines say that pharmacists have a very important role to play, there are these contextual factors that we need to consider when we are trying to develop pharmacist roles and trying to create more opportunities for pharmacists. So with that, I would like to actually thank a lot of collaborators from across the globe, and also from my hospital, the GI surgery and CVTS team and the stewardship team who contributed to the qualitative research studies that I mentioned. So thank you so much for your patient listening. Saidulu, you're on mute.
Yeah, thank you, Vinda, for such a elaborative presentation on a complex topic. Anyways, it's very new to us, like especially pharmacists in India.
Yes.
I try to get a couple of questions from your
Okay.
presentations.
Okay.
So, how to grade the quality research findings like in the guidelines? Suppose if you see all the like clinical guidelines from the quantitative research, they're like grade 1, grade B, grade C, like that. Is there any way to we can grade these qualitative research findings?
As far as I know, we don't actually grade these evidences because it's basically giving you a behavioral aspect. It's not giving you a quantitative finding, not giving you a recommendation in that aspect. So as far as I know, there isn't anything.
Okay. So basically, these findings is to help us to frame the guidelines better.
Yeah, so basically to understand the context better. So understanding the context is more important. Understanding the culture here is more important when you're developing guidelines. So we keep saying that, guidelines from the West is not applicable to our patients.
Okay.
So similarly, guidelines that are developed in the West is basically looking at the dynamics there. And
Okay.
those guidelines you can't blindly apply to our patient population. So similarly, even in India, every hospital, every department, their behavior is different, their context is different. So those factors also need to be considered when you're developing guidelines. For example, like I mentioned in my presentation, the role of bystanders. Western countries don't have any role for bystanders. There are no family members who are actually staying with the patient. There is nothing that they are doing for the patient while the patient is in the hospital. But that's not our case. That's a very contextual thing for us. So
Okay.
these nuances need to be considered when you're developing guidelines.
Okay. Take it. So basically, the qualitative research is the background or pillar for the developing the quantitative research.
Yeah, it adds to the quantitative findings. It gives you more broader picture about the numbers that you're gathering through quantitative research.
Okay. So the one question about that, the different things, the focus group discussion,
Hmm.
how do I choose the responders, the different responders? Suppose I'm working on some clinical questions. So shall I need to select the responders from the same background, or shall I select the different background people? Suppose physicians, surgeons, and pharmacists like that, or I can only choose the only physicians for that particular related question.
So there is no right or wrong rule there. So you go with what you think is the best approach. So you would know that, when it's different hierarchies that come together, people may not be open to speaking. So if you put like a senior consultant, a nurse, an OT technician, a pharmacist in a room, all of them may not be able to speak to the same level. But if
Okay.
you keep all pharmacists together, they may be more open to speak up.
Okay.
So it's always better to do a few observations to just understand the context, to understand what's like the dynamics in the department, and then go for focus group discussions rather than just blindly going for it. That's what I would suggest. Again, that's not a mandatory thing, but I would suggest that, first get a flavor of what the department is like, what's the dynamics like in the department, and then select your participants. See, so when we did the focus group discussion here, we tried to bring certain professionals together. So we didn't try to mix professionals. So we kept OT technicians separately, we kept surgeons separately, we kept intensive care unit team separately. So we kept different focus group for different professionals. So that's from our findings, our observation, that we thought that would be the best approach.
Okay. Then one thing you explained about one case in the MSP, surgical prophylaxis, some surgical site infections. So there you tell that the decision makers is different in different settings.
Hmm.
So like how to overcome these some different decision makers, and how to improve the communication from the pharmacist side to the different decision makers. Is there any like simple ways to understand the pharmacist to follow?
So communication skill is very, very important. Like I mentioned, whenever you're giving your recommendation, it should be tailored to the recipient. So rather than just, so we all say, one size doesn't fit all. When we talk about antibiotic dosing, we always say that. We say that, each patient is different. Similarly, each consultant is different. Each healthcare professional is different. So how you communicate your recommendation to a surgeon is very different to how you communicate it to a general medicine physician. So
Okay.
I did mention about, say, for example, for surgeons, when you talk about antibiotic resistance, those are not parameters that matter to them because they are more worried about immediate results for the patient. So for
Yes.
them, the priority is that, the patient needs to not have any infection during the hospital stay. The patient should be discharged fine, should not have a prolonged hospital stay. So these are the parameters that matter more to them. So when you talk to them about antibiotic resistance, which could come, later, it's not something that they are going to see immediately. So tell them in terms of, surgical site infections. That's a parameter that really concerns them, or hospital readmission rate or mortality rate. So tweak your recommendations in a manner that it catches the attention of the recipient, rather than just going and saying the same recommendation to everyone. That's main thing I would say. Saidulu, you're on mute.
Thank you, Linda, for your patience and answers. I think we finished the questions. And
Okay.
thank you from the FCPI, and thank you for your team.
Thank you so much, Saidulu.
Good session.